Okay. Very good afternoon, everybody. I know this is lunchtime, but what we are going to talk is very important. So, whoever is there, we hope to give some valuable practical points. The session before this, last session, was on medico legal cases. There were many discussions on endophthalmitis and cluster endophthalmitis. So, this is something which we have to be careful. One case of endophthalmitis will be enough to create a nightmare in our minds. But imagine having a cluster endophthalmitis, it is going to be a major problem for rest of our lives. It is not going to go off the mind. But today we are in a position to manage cluster, and we are also in a position to prevent a cluster. So with this in background, so I thank Dr. Rajiv and Dr. Sashikumar sir, two seniors. We are all passionate about infection control, and I hope we hope to give you some valuable points. So if you see here, these are the things that can happen now. There are so many things that are being done for infection control, like various protocols. We have, unidirectional flow in the theatre. We have double doors in the theatre. All the new OTs are well equipped to prevent infection occurring. Starting from the era of amphitheatres, now we have moved on to eye theatres, which are very highly sophisticated, and operation theatre is the heart of the eye hospital. Now, if you look at it, the NABH gives some guidelines, and there are standard guidelines for operation theatre. It should be in the floor at the top where there is minimal traffic and so on and so forth. So there are something called super specialty OT and general OT. But general OT is under which the IOTs come. It is not like a super specialty OT. So there are three types of single theatre. Many of us will have twin theatre suites are there, and OT complexes with many OTs, except very big hospitals. So we come under general OT. Now this is very important to zone the theatre, because we do not want crossover of used and sterilized items. That is why we categorize them into at least sterile, semi-sterile and non-sterile zones. So ideally it is divided into a protective zone, a clean zone, an aseptic zone and a disposal zone. So now what do we mean by all this? We have markings also. It could be red, yellow, and the green would be the most sterile area. The protective zone will be an area where we enter, change rooms and store rooms and all. The clean zone would be a corridor, transfer rooms and patient recovery area and so on. The most important is the aseptic, which will be the part of the CSSD and the operating room. So now we have a disposal corridor, like how I showed you. There is something where there will not be a crossover between the sterile and the unsterile. So what are we seeing here? We are seeing one which is coming up just like that, and a one. So manually constructed OT versus modular OT. Modular OT is there. There are many advantages, but it is not mandatory. It is not at all mandatory. A regular OT is as good as a modular OT, but a modular OT can be customized, maintenance, and it is a long-term prospect for any hospital. The heart of the theatre is the CSSD. So you all understand now the CSSD can be done even in a small single theatre complex or a multi-theatre complex. There are three zones. One will be where you receive the soiled zone, used items, then there will be a barrier, then it comes to the cleaning zone where you clean it. You have where you receive the soiled items or the used things, you can do all the inspections, take off all the unwanted things. Cleaning zone will be, there are various steps which Dr. Rajiv will show. Once it is cleaned and packed, then it goes into the sterile zone where the CSSD, your autoclave will be there. So between the clean zone and the sterile zone, ideal to have an autoclave, which is a double door autoclave. One side you put in the packed items, the other side you get the sterilized item and put it in the storage area. This is the best way to construct an OT. This is the unidirectional flow, and this is not acceptable at all in the newer CSSDs, or even the older CSSDs can be modified. So this is where we get everything, clean it, you can do it manually, automated, check for patency, all the broken things can be taken. Then you have the packing. After cleaning, packing, you do the packing there. There are number of ways of packing, not like the older ways of, even still we do this bin packing, but there are specific packings for each set which Rajiv will show. The sterilization area is a CSSD. We can have a double door autoclave, ethylene ETOs and plasma sterilizer. Then again, the storage area should not be close to the wall, should not be close to the floor or the roof. The temperature should be 24 and all the needs are there. Your validity will depend on the type of sterilization. So from the floor it should not be touching, near the ceiling it should not be there, no cardboard boxes, make sure there are no insects anywhere. Now coming to a word about surveillance, which I need to cover at the last, but after my talk and Dr. Shashikumar's talk, it will be Rajiv all the way with his videos. So we need to, when you talk about surveillance, you have to take care of the surfaces, air and water. These are the three important things. Though there is no need for swab at this point in time, that National Program for Control of Blindness would say you will need to take swabs at least once in 2 weeks. The settle plates are for the air. You can keep it in at least 5 places away from the wall at a height of about 1 meter above the ground, 1 meter from the wall, exposed for half an hour or 1 hour, whichever is the protocol. And then you have the reports. It has to be done periodically. Sometimes what happens, the hospital does it, they get the reports and file it. Then when they get an end off, they will realize there was an abnormal count. When you have a HEPA filter, it should filter 0.3 microns at the rate of 99.7% efficiency. So these reports need to be done once a year or once in 6 months, depending on the usage of the hospital. The air sampling can be taken, ideally we all take the settle plate methods. Water, we need to test it physically daily. Chemical testing at least once in 6 months. Microbiology testing, ideally once a month would be good, and RO water again should be tested every month. So this endotoxin level is something which is important. You have to give it out and test it. Microbiological surveillance will also include E. coli. You know, this counts, you cannot get 0, but you have a low risk water. Now these are the reports we collect periodically, and the chemical analysis we get to make sure that the water is good. The endotoxin level should be within acceptable limits. Recently we had maybe a few months back cluster of TAS, and we found that endotoxin was very high in some kind of IOLs. The AOS has formed an adverse committee, registry. So there is a committee for this with a mixture of all sorts of microbiologists, even a legal expert. If there are any problems, it could be a TAS or it could be endophthalmitis, which is a cluster, you can report. The AOS team will support you, and maybe if necessary they will also give a legal support. In Tamil Nadu, under our President Dr. Nirmal, we have a Quality and Infection Control Committee where our dear Rajiv is also one of the advisors. So we do 4 programs at least a year, and we also help people who needs. So this is in gross about the zoning of OT and surveillance. Now I hand over to Dr. Shashikumar's sir for his next talk.